we actually got this weight-bearing MRI from Esaote nearly over 9 years ago. And when it came, it created a lot of news, both in the press as well as on television. This was the front page of the biggest circulating newspaper of India, which has millions of subscribers, and there were so many more. The excitement was for the fact that it's an open MRI system, and also that it would be capable to do weight-bearing MRI, something which hadn't been possible in this part of the world at that time. This is March of 2011, and it even made it to the CNN. And this is a shot I got from there. And over these 9 years, we have really extensively used this machine. To tell you my background, I had before this only used high field MRI, 1.5 and 3 Tesla, and was reluctant to use low field open MRI systems. But with the image quality that we could see with this machine, and also the fact that you could scan a patient in the sitting or standing position, this for me was a revolution. And this tilting MRI can be used. We are going to talk about clinical relevance today, and I'll be sharing with you some of the cases, mostly in the spine. But we'll also look at the ankle, the knee, and the other joints. We have recently ordered another G-scan, a new G-scan, which is also now capable of imaging the brain. And that's also very exciting for us. Now, if we talk of the spine, low back pain is extremely common. If we look at the incidence of spine pathology, as this slide shows, about 58% is of the lumbar spine and 22% of the cervical spine. These are mobile parts of the spine, and that's why the problem here. Now, most of us will suffer from low back pain during the course of our life. And if we look at healthcare costs for spine pathologies, and this is a slide from about 4 years ago, $50 billion, and worldwide about $100 billion are spent on pathologies of the spine, and it's a very, very important cause of absence from work. Now, weight-bearing imaging has been there. This is the X-ray of 1945 with the upright stand on which the cassette used to be put, and we would get weight-bearing or standing images of the spine. This is how it is done today using digital systems where it's possible to image the entire spine and, of course, the whole body weight-bearing MRI that we'll be talking about today. This capability has been there for about over 12 to 13 years. Like I said, there is a new magnet which has just been introduced, which is able to provide much better image quality as compared to what we had earlier. And this, I'm sure, in the months and years to come, is going to open up many more areas of application. Who really are the users? The radiologist, of course, the spine surgeon, the orthopedic, the physio, and those who have multi-dimensional approach to things. And apart from the spine and the joints, we are now, like I said, able to image the brain. Now, when a lesion is detected with an MRI, there are some real questions. we all who've been doing MRI of the lumbar spine, we actually may find coincidental findings. So we have these questions, which ones are really related to low back pain, and can weight bearing provide additional information? And also we want to see what is the response of some anatomical structures to load. The other questions may be that when a patient is getting pain on sitting and standing and a routine high field MRI is negative, why is that so? When there is post-operative persistence of pain, many times we don't find the reason on doing routine MRI. Then we need to take decisions on stabilization of the spine. The spine surgeons need to take this decision, and what kind of hardware to use, even whether to use hardware or not. Then for the physiotherapist, rehabilitation planning post-surgery. And of course, there is the difficult concept of instability of the spine, which means different things to different people. These are questions which I feel over the last 9 years, most of them can be answered with weight-bearing MRI. The additional benefit of costs, as you can see the machine, it's an open system, and patients who are claustrophobic actually love it. And by using an open MRI system, the percentage of people who refuse an MRI is drastically reduced, because only, as you can see here, the part to be scanned is within and the rest is all open. This is not a tunnel. So the machine itself is very patient friendly. A lot has been written in literature. There are more than 200 publications as of this year, which are there in literature. And even last year, there were over 20 scientific publications and many seminars in musculoskeletal and spine imaging. And of course, most of these say upright MRI is superior to supine MRI for diagnosing degenerative spinal cord disease. And another conclusion that the upright MRI is useful to assess instability of the lumbar spine, detecting hidden modifications of protrusions and or herniated discs already present in the spine in supine position. It is also helpful in assessing the presence or modification of spondylolisthesis and lumbar canal stenosis, and these are cases that we will see. Now, this is a supine image on your left and a weight-bearing image on your right in a patient which we did over 9 years ago. This was the third patient we put in our MR magnet, and you can see that even though this is an upright and an open and a low field permanent magnet system, the image quality is quite good. It is diagnostic, and you are able to see this very, very well. One difference which we found and which is always there between a supine scan and a weight-bearing scan is that the lordotic curvature of the lumbar spine gets exaggerated when one is standing, and this is a normal finding. Of course, the disc, the lower end of the spinal cord, the chorda equina, the vertebral bodies, all of these can be seen very well. And this is thin slices that we've obtained. It was surprising for us that we could do 3D imaging using new sequences that had been developed by Esaote. This is a 3D HICE acquisition in the axial plane, and you can get, and these are 3mm slices which you've got in the axial plane and which are able to show you with great degree of clarity abnormalities. And what you can also do after acquiring it is get slices inclined along the axis of the discs themselves and look at them. These are reconstructions along the IV discs. And from this one axial acquisition, which is 3D, you're able to also actually reconstruct fairly decent images. They may not be very high quality, but decent images even in the coronal and the sagittal plane. So if you have an uncooperative patient, you can just do one series and then reconstruct in the other planes. We move on to the clinical cases of the lumbar spine, and this is a very dramatic case, which is the case 2 that we did on this machine in the year 2011. This was a patient who had been treated for tubercular spondylitis, had been fine, then again developed pain in the spine and radiculopathy, especially when she used to stand or sit. This was a patient who came to India from Afghanistan, and a high field MRI had been done, and which did not show any compression. And then she was sent to us because the referring surgeon came to know that we had just installed this new weight-bearing MRI. And this is what the scan looked like. That's a FSE T2 weighted image on your left, a T1 weighted image, which showed that there was signal alteration within the L5 and S1 adjacent vertebral bodies. The disc height was well maintained. There was some increased signal within the disc, and our diagnosis on this was that there could be reactivation of the old tubercular infection. But why the patient is having radiculopathy, we could not make out because there was no compression on the nerve roots. And this is what happened. This is the axial showing no compression. And this was a patient who we made her stand up. And this was, like I said, our second case ever done on the upright MRI. And this patient was in great pain. This was a scan done in 1 minute 42 seconds. The image quality and the movement artifacts may not look very good, but there was huge information in this image. And here what you can see, I will take you to the next image. This is the supine scan, and this is the standing or the weight-bearing scan. You can see the height of the disc here was normal, whereas here, and there was no pressure on the thecal sac or the nerve roots, whereas here we could see that the disc had protruded. This material had protruded, was causing a lot of compression of the thecal sac. Also, there was a forward bending of the thickened ligamentum flavum, which we could not make out on the supine scan. And so if we see, this was the height of the disc before on the supine scan, this is on the upright scan with this compression. So we could on this get the physiological data, knowing we could see why the patient was having the pain on standing or sitting, because that caused pressure on the spine, on the disc, the protrusion. And so this case actually was a huge learning for all of us, our orthopedic surgeons, our radiologists, and our neurosurgeons, that weight-bearing MRI was dramatically useful. This patient was taken up for surgery and spine fixation and did very, very well, apart from anti-tubercular treatment, and did very well. This is another case, and this we've been seeing very often. This is a case done on a 1.5 Tesla MRI, who was then, had a lot of pain. There were symptoms of claudication, of lumbar canal stenosis. The patient could walk only about 20 meters and then had to stop because of claudication in the calves, because of pain in the calves. And on this supine MRI, you could not see much of compression. There did seem to be some ligamentum flavum thickening, but there was no disc herniation. There was not much pressure on the thecal sac or the nerve roots. And that is what we also saw on the supine MRI that was done on the G-scan. But when we put the patient upright, you can see why the patient was having claudication. You could clearly see that there was a disc bulge at L4, L5. and actually the thickened ligamentum flavum was protruding forward and leading to rather severe lumbar canal stenosis, which you cannot at all see on the supine scan. So this case dramatically tells us the advantage of weight-bearing MRI and of scanning the patient in the position in which they get the symptoms. Another case, this is supine on your left, standing on your right, and this is again a case degenerative lumbar spondyloarthropathy, degenerative disc disease, and multi-level disc bulge and herniation, ligamentum flavum thickening mildly at multiple levels. This patient also had symptoms of lumbar canal stenosis, but the stenosis here on the supine scan was not much. But when we made the patient stand up with weight bearing, you saw that there was actually marked increase in the stenosis, and this was able to explain the lumbar canal stenosis. So these two cases, the one here and the one here, can show you how the weight-bearing MRI correlates with the symptoms that the patient has. This is yet another case where this, apart from this mild disc bulge here at L3, L4 level, everything else looked normal, mild degenerative change in the discs and little disc bulges, but nothing to explain the radiculopathy which happened when the patient stood. And in the standing position, you can see forward buckling of this mildly thickened ligamentum flavum, increase slightly of the L3, L4 disc bulge, and this, even though subtle change, but it was clinically significant change and could explain the patient's symptomatology. Another case who had radiculopathy, and when the patient lay down in bed, there was no problem. The moment the patient stood up, he got pain, and this is supine on your left and standing MRI on your right. And here on the axials, you can see there is mild narrowing of the right lateral neural foramen due to this disc protrusion. But on weight bearing standing, you can see marked compression, and this could actually explain the radiculopathy which the patient was having much better than what could be seen on the supine scan. Spondylolisthesis, again, is a disease entity where weight bearing can play a major role. Most patients have symptomatology when they stand, when they walk, when they sit. And this is well brought out by this case, grade 1 spondylolisthesis. On the X-ray, they could see this break in the pars interarticularis here. And this is supine MRI, and this is on standing weight-bearing MRI, where you can see the disc height has mildly reduced. You can measure. You can also measure the extent of the increase in the anterior translation of L5 on S1 vertebral body from 8.73 millimeters. It has increased to 11.57 millimeters. So we can know that this is a unstable area, and apart from anything else would need to be fixed. Another case of spondylolisthesis where you can see both at L4, L5, there's a mild disc bulge, degenerative disc disease, mild disc bulge here. And what you can see is that there is unfolding of this listhesis. It's only a mild grade 1, but it gets unfolded here. And again, this is a consistent finding that we have, that the ligamentum flavum tends to buckle forward and compress the thecal sac from the posterior aspect when we actually make the patient stand in the weight-bearing position. And so this is something which has been brought out very clearly on thousands of weight-bearing scans that we've done. And so looking at this, no one would suggest surgery, but looking at this, you know that surgery is unavoidable. It has to be done, both the decompression as well as the fixation. Spondylolisthesis grade 1 with degenerative disc disease, mild disc bulge, and on standing becomes grade 2. Again, another case which is unstable and requires fixing. So this is information which the orthopedic surgeon really wants in case he wants to go in for surgery, and also the physiotherapist, the pain specialist needs to know this before going in. And we may get this information on an X-ray also, that there is instability. But what MRI gives in addition is the degree of the disc herniation, the narrowing of the neural foramina, the compression of the nerve roots. Those can all be brought out much, much better on the MRI. Yet another case, and this was a 91-year-old lady with low backache. And this case I've put to show that even the elderly, if they have been made to understand nicely, they can undergo this examination in the standing position. And here I'd like to say that it's not necessary for you to make the machine, the MRI system, stand at 90 degrees. This is a tilting system. So from 0 degrees to 90 degrees, you can make it stand at any level and still be able to get significant weight bearing. Normally, we tend to make the machine stand between 70 to 80 degrees because that gives the patient some relief. Because remember, these are patients who get pain when they stand. We have to do the scan very quickly. We have to also make them as comfortable as we can. And with a tilt of about 70, 75 degrees, they still get some support from the magnet table and are able to withstand the examination much better. So here, in this lady, we were able to unfold this slight grade 1 listhesis which she had on standing. Of course, there was no surgery or anything done for this lady. She was just given some exercises to keep the muscles of the back toned up, and that's what was done for her. Now, this is an interesting case. This was a member of Parliament of India who came to us and who said that when I sit in Parliament, after about 1 hour of sitting, I start getting back pain. So he was also claustrophobic. So he came to us for the MRI scan. And here we found degenerative disc and a mild disc protrusion at L5S1 level on the supine scan. But we went ahead and also did a weight-bearing standing MRI. And here what we found that there was a very mild retrolisthesis which was seen L3 or L2 on L3 vertebral body. And actually, this is the level where he used to get localized pain. So we were able to tell the orthopedic surgeon and the physiotherapist where the pain was in relation to his MRI. The symptoms matched, and with exercises and physiotherapy, they were able to improve this. And the L5S1 disc was just coincidental. It was a red herring. And so this instability could be taken care of by toning up the muscles of the back using physiotherapy. This is another case where, again, multi-level disc, there's retrolisthesis of L4 on L5 vertebral body, a disc protrusion, disc bulge at multiple levels. But here what we found that there was no instability on making the patient stand. So this was a stable spine. And also we found that there was not much of increase in the compression at multiple levels on standing. And so this also may happen. What we found in our series that in about 40% of patients where we did with low backache, where we did MRI supine and standing, in 40% there was exaggeration of the abnormality that was found on the supine scan. This is another case, foraminal stenosis, which is seen very nicely. Here you see a teardrop-shaped neural foramen, teardrop-shaped neural foramen at L2, L3, L3, L4 on the supine scan. But on the standing weight bearing, you can see there's narrowing of the neural foramen inferiorly at both these levels, and this could explain the abnormality. Also, there was unfolding of this L4 on L5 grade 1 mild spondylolisthesis and minimal retrolisthesis L3 on L4 and slightly more prominent retrolisthesis L2 on L3. And all these would be very helpful to the treating doctor in determining how to go ahead and treat. Also, facet joint instability is another area. Facet joint disease actually is the last thing that we look at as radiologists, and it really gets missed. But as you can see here in this patient at the L4, L5 level, there is facetal spondyloarthropathy, and you can see effusion within the joint. There is hypertrophy around the facet joint. There is thickening of ligamentum flavum. But on standing, we could see that there is instability of the joint. Here, it appeared to be absolutely opposing very well, but there was instability with this part of the facet joint actually moving in relation to the one here. And this explained the pain that the patient was having on standing up. So as I've shown, in all parts of the lumbar spine, especially degenerative disc disease, a weight-bearing standing MRI plays a huge role and gives you incremental information which you may not get on even a routine scan. It can show you exaggeration of abnormalities. It can pick up abnormalities which may not have been seen at all on the routine supine MRI, and also the exaggeration can lead to changing your approach to management, surgery versus no surgery, certain kind of physiotherapy versus a different kind, and use of hardware, metallic hardware versus no metal. So in conclusion, I'd like to say that this is a modality that has been here for over a decade. We've used it extensively, but maybe not as much as it should be used. This is a modality where you're able to image the physiology, the pathophysiology of disease of the spine and the joints of the CV junction. And we need to use this more and more, because doing supine MRI may be one way of looking at it, but doing weight-bearing standing MRI is the right way of doing it, especially in degenerative disease and in the other areas that I've tried to show you. So I would say the future is here. And I would like to quote one of my heroes, Jack Welch, who was the chairman of GE, and he said, change before you have to. So I would say to all those who are attending this seminar, this webinar, that let's try to embrace this pathology, because this is able to give answers to many questions which a supine MRI cannot give, be it a 1.5, a 3, or a permanent MR. This is going beyond just anatomy. This is going to physiology and pathophysiology, and it must be used. Thank you so much for your attention.